It's really my great pleasure to introduce Governor Mike Leavitt, founder and chairman of Leavitt Partners. He has served as a 3-term governor of Utah and as Secretary of Health and Human Services with George W. Bush's administration. As HHS Secretary, he led the implementation of the Medicare Part D prescription drug program. And 10 years later, you all may know that 70% of Medicare enrollees are now in Part D. Governor Leavitt also has a unique perspective for helping presidential candidates. He led the transition team with Romney Ryan, referred to as the gold standard by both Democrats and Republicans. And he continues to be a sought-after advisor. I know Speaker Paul Ryan mentioned him recently as somebody he consults with regularly. Currently, he's a volunteer with the Center for Presidential Transition, housed in the Partnership for Public Service, and is available to both parties for questions about how to run the transition teams. Please join me in welcoming Governor Leavitt to the podium.
Am I the only Tom Clancy novel fan here? Any of you read a Tom Clancy novel? So could I suggest that one of my favorites is a novel referred to as Executive Order. It is a thriller that actually took place on Capitol Hill, where the nation really gathered for the purpose of being able to celebrate the inauguration of a new president. Regrettably, there was a terrorist event, and bad things happened. A lot of people died, including the president and the president-elect and vice president-elect. And what unfolded in this novel was a question of who actually would be in charge in such a situation. I won't spoil the plot for you. You can read it, and you would enjoy it. What I will say is I suspect, having read that book, it was of particular interest to me when I was sworn in as a member of the President's cabinet, that I was taken by people, very serious people who drive black cars, to an undisclosed location, where it was explained to me that I would be, as a member of the cabinet, in the line of succession, that I would have certain obligations under that task. Now, you were never in any danger. I was a long ways down. But it was a very serious task, and it should be. I was told 2 things. One is that I should always carry what you see in this picture in my wallet. It was a card presented to me that was a plastic card, and I was told that if there was any moment where the wrong things happened and there was a likelihood that something could occur, I should find a telephone, I should break that card open, and inside I would find a telephone number and some numbers that I could authenticate in the right way. And if in fact it occurred, that would be the way in which I would demonstrate that I was the person to next be chosen as the president. Now, again, as I said, you are not in any danger. But the second thing is that because I was in that line, I would receive on a regular basis what all of you will know to be the President's morning briefing. Now, this is a process where a member of the intelligence community would come to my office. We would go to a specially prepared place where they would begin to describe for me what was happening in the world, and they would pull out a document stamped top secret. The process that was used, very simple, basically. They come up with a series of uncertainties, and then they collect information from around the world, and they are then able to put it in front of a bunch of smart people, and they're able to say, when you look at the dots on this page of information, what picture do you see? And we can begin to tease out things that will help us understand what could or happen in the future, and if those are bad, how we could avoid them, and if they're good, how we could take them as an opportunity. It's a process that is not just used in government, it's obviously used in any kind of a setting where decision makers are dealing with uncertainty. Well, it's obviously a very important process. as a man who was a veteran of this said, what we're looking for is we're trying to make sense of weak signals. If we're able to make sense of the weak signals, then we have the opportunity to take advantage of opportunity or to avoid disaster. This is a picture all of you will remember, having seen before. December the 7th, 1941, Pearl Harbor. It's a day that the entire Pacific Fleet of the United States was lost. After that occurred, there were a lot of people wondered, how could that have happened? How could we have lost such an asset at one moment and have been so unprepared? Well, there were hearings that were held in places like this room, where testimony was taken and studies were done, and there were pages of weak signals that were determined to have been missed. For example, it was determined that we knew that the Japanese were not allowing access to any of their naval facilities. We knew that they were gathering targets of British and Dutch and American sites. We knew that, in fact, there was a report from the Secretary of Navy and War saying very easily they could attack Pearl Harbor. The day before this attack occurred, a ship was seen in Hawaiian waters. And maybe one of my favorite was December the 6th, or 7th rather, the day of the attack. At 6:40 a.m., there was actually a submarine that was sunk by the USS Ward. And as they were coming back, they could hear explosions on the other side of the island. And the commander said to the first officer, "Oh, it sounds as though they are working on the road between Honolulu and Pearl Harbor." I think that's significant in the context of knowing the future, because we often look at the future and try to put unusual events in the context of what we know and understand. So my purpose today is, I hope that you'd think about what we're doing as really a kind of intelligence briefing, if you will, on the future of healthcare and where this is going and the weak signals and what they're saying. I'd like to talk about two things. Long term, will in fact fee-for-service payment be replaced by value payment? In my judgment, one of the most significant changes that's happened in healthcare since the widespread adoption of health insurance. And secondly, I'd like to talk short term. What are the issues that will confront a new administration and a Congress in 2017, despite the outcome of the election? Now, what you'll see here is what's known as the diffusion of innovation curve. And this is a curve that is used whenever there is an innovation, whether it's the iPhone or whether it's a big change in the payment structure as we're going through today. I'd like to highlight this quote of Bill Gates. "We always overestimate the change that will occur in the next 2 years, and we'll underestimate what will occur in the next 10. His advice is, don't be lulled into inaction. I'd like to talk a bit about what we all know today as ACOs, or Accountable Care Organizations. A lot's been said about that, but the question is, what's actually occurring? This is a map in 2010. The splotches, the darker they are, the more there are. I'm just going to run through quickly: 2011, 2012, 2013, 2014, 2015. It's very clear that this method of payment is becoming more prevalent. Now, that doesn't mean it's predominant yet, but there is clear motion. This is the number of hospitals in 2010 that were actually involved: 2011, 2012, 2013, 2014, 2015. You can see there's a lot of activity. The smaller open dots are those who haven't. There's still a lot to do. This demonstrates the number of contracts and the growth that's occurring. You can't see it in the back, but you can see the convergence of the lines. Basically what it says is, the weak signals are saying there's still a lot of new contracts being let to do this between payers and providers. However, there are fewer new ACOs being formed, but more contracts as we move forward. This demonstrates a projection of how many lives currently we believe, in the research we have done, that there are roughly 28.3 million lives that are currently on some kind of payment structure other than just fee for service. Now, if you were to put that on this diffusion of innovation curve, you'll see we're right at the beginning of this process. And that's a very important point. We are just at the beginning. As much talk as there is, not very much yet has occurred, but it's clearly moving toward adoption. Now this, again, it's going to be hard to see in this big room, but could I just point out that we've broken this into 4 cases as to how quickly it would occur and how complete it would be. The first one on the upper left is basically the base case, and if you can see a blue line and a red line, the red line is what we believe will occur, and the blue one is what's happened thus far. But you can see if things operate just as they were, that we'll get to roughly 105 million lives by 2020 that will be part of this. To the upper right, this is a baseline without MACRA. I want to pause there and say quickly, MACRA was a very important piece of legislation, not just because of what it implemented, but because it demonstrated that there is bipartisan support for a change in this payment structure. Bottom left says, what happens if no one makes any money at this? Obviously, that means people aren't going to adopt it. What happens if they're wildly successful? So as you can see, there is progress being made. It will be somewhere between 40 and 177 million lives. It needs to be tracked very carefully, but the weak signals are clearly demonstrating that the change in payment is beginning to happen. Now, I'll just say we're not very good at this yet. There are a lot of people who are not ready for it, and the timing is a critical issue. But from understanding where the future is going, this, in my mind, is a very significant development historically. Now I'd like to talk about what the weak signals are saying with respect to the new administration and Congress. Obviously, we have a campaign going, and we don't know who will control Congress in either chamber, and we're not certain who will be the president. But I'd like to suggest that there are at least 3 topics that I believe the new administration and the new Congress will be dealing with early in 2017 without respect to the outcome of the election. The first is the fragile individual market. 10 million people now are in the individual market as a result of actions that's been taken in the past. It is demonstrating currently to be fragile. Now, there are lots of reasons for that. I think it's predictable that at the end of this election, one party will say, see, we told you that would not work without a public option. We need to have a public option. The other party will say, we told you if you didn't organize this market correctly, it would not function. And therefore, we need to go back and either change the system or we need to fix that problem. In the balance are 10 million people who have health insurance, and it's my belief that, first of all, it needs to be responded to, and second of all, those of you who are involved in health care will be involved in this debate in early 2017. The second is the environment for Medicaid expansion and 1332 waivers. Obviously, not every state now has adopted Medicaid expansion. We're moving into a new administration. The new administration, whoever it is, will not be wedded to that of the past. If we have a President-elect Clinton, it seems likely to me that we will, in fact, begin to see a push for more Medicaid expansion. I think we'll begin to see more flexibility offered by the new administration as an incentive to do that. And frankly, I think we'll see state legislatures and governors who are willing to have that conversation. The 1332 waiver is a fascinating new development. It's coming effective in January the 1st, 2017, where there's a tremendous amount of new flexibility built into the law. That could be interpreted in ways that could make it a boon to Medicaid innovation, or it could be used in a way as to say, we're not changing at all. Time will tell. That is a conversation that we'll have beginning in January. And lastly, pharmaceutical pricing. I won't delve into that. I think everyone is aware that that's an issue both parties are feeling needs to be focused on. Now, it's very rare that I have an opportunity to speak to a group of people like you who are engaged in public service. And as a person who has, in fact, spent a good chunk of my professional life in public service, I'd like to take advantage of this moment to just give you a piece of advice. This is a picture that I took in 2002. In 2002, the state I was governor of hosted the Olympics, the Utah Olympic Winter Games. One of the great privileges of that is that I had the chance to go to Olympia, Greece, and see the Olympic flame lighted. This is the scene. These Olympic goddesses that you can see walked out of the woods. And one of them, one kneeling on the ground, held a torch. And she held it in an Olympic salute. And then she put some flammable material of some sort into that bowl that you see. It's concave. And suddenly the sun began to beat down on that bowl, and I could begin to see some smoke. And then that sound as the flame burst into being. It was the first time in many years of preparation I realized the Olympic flame is actually the sun. But she lighted the torch and she held it high, and then from the side came another runner. This one wearing a uniform of the Utah Winter Games. Chills went up and down my spine, as you might expect, and that runner also held a torch, and they held them up together. There was a transfer of the flame. The runner then turned and began to run, and that exchange of the flame took place almost 12,000 times, and the run traveled over 13,000 miles. What was fascinating to me is that everywhere the torch went, people came by the thousands to see essentially fire on a stick. One day, I'm with the woman who is organizing it. I said to her, I don't get this. Why do people come to see fire on a stick? She said, you're right, Governor, you don't get this. Let me explain it to you. 2 weeks ago, she said, I went to an area where we had a gap in the runners, and I sent my assistant ahead in order to get a runner. And she went into an elementary school, and she said to the school secretary, quick, I need a runner, but don't give me the student body president. Give me somebody that'll get a bit of a lift out of this. The school secretary said, I know exactly who you're talking about. And within about 5 minutes, they were dressing an undersized fifth grader in the Olympic uniform. Well, they went to the street, and the runner came closer, and as they approached, there was a meeting of those two flames. They lighted. He took it with both hands and began to run down the street with tens of thousands of people on the side, including his classmates. The woman said to me, last week I got an email from the school secretary who told me what a great experience it was for their school. And then she said of the undersized fifth grader, he doesn't sit alone anymore. That, she said, is what the fire on the stick is about. It's about what it can do to the human condition. It's about what sport can do to bring us together as a people around the world. I tell you that story in the context of the service opportunity you have. Because as we talk about the weak signals, we're not talking about business models. We're talking about lives, and we're talking about the opportunity that you have to be in a unique position to positively affect the lives of other people. So my challenge to you is that we keep the fire on the stick in our mind as we begin to think about the opportunity that lies ahead in the new Congress and in the new administration, and that we begin to look for solutions. And if we do, our country will stay a prosperous and good place. Thank you.
Now it's my great pleasure to introduce Bob Kocher, a partner at Venrock, a venture capital firm where he focuses on healthcare and IT investments. In speaking with him, you'll know immediately that he is truly on the pulse of the future of healthcare, advising and co-funding innovative care delivery and digital health companies. He also brings a unique perspective to today's discussion regarding the future of the Affordable Care Act. He served in President Barack Obama's administration as a special assistant to the President for Healthcare and Economic Policy, where he helped to shape the ACA. And he was the only physician on the National Economic Council. Prior to working in the White House, he was a partner at McKinsey & Company, where he analyzed healthcare delivery systems around the world. He is truly passionate, and I have to say also optimistic about improving healthcare in America. Please welcome Bob Kocher.
Good afternoon. Thank you for sharing your lunchtime with us. I think we have strong signals that healthcare is actually getting better faster today than it ever has in America. And so I am excited about both the care that we can all receive today and how much better it will get for more people over time. I say that for a couple reasons. I now live in California, where I spend my days working with entrepreneurs who want to bring product insight, bring data, bring technology, bring new ideas to healthcare to make healthcare better. And I live in a place where we're seeing the hospitals, insurance companies, employers, and patients actually want to make healthcare better faster. So I come to you with joy that we're seeing this happen. I'd observed that in just the last 5 years, there's actually been 1,000 new startups created in just healthcare IT and services. There's been $10 billion of incremental venture capital put into the healthcare economy. We've seen widespread adoption of technology, and with technology comes all that data. And one of the neat things that's occurred is that this is the Health Data Initiative, which has liberated more data just in the last year from HHS than the entire history of HHS prior to last year. So now we can, for the first time, know prices, quality, referral patterns, which medications work for which patients, find people for preventative care and get them engaged. There's amazing things happening with technology and data. Two other things that give me great optimism are an influx of proven technology entrepreneurs who've said, I figured out how to track us, I figured out how to sell you an ad, I figured out how to engage you in a game. I want to now work on something important like healthcare. And so just in the last few years, we've seen executives from Facebook, Google, Apple, Trulia, LinkedIn, all create new healthcare companies, and with them come engineers and product people who know how to make really great technologies to make healthcare better. The last thing is we're on the cusp of a host of really interesting technologies that have many easy-to-imagine applications to healthcare. So whether it's big data and machine learning to look for irregularities or make sure you're on the right clinical treatment path, or things like virtual reality to help train doctors on how to be better. We have many things that are just coming to the market that I think undoubtedly will change the way in which you experience healthcare in 5 years. Let me look back a little bit to give you a sense of why I feel this way. First, the Affordable Care Act, despite all the angst that it may have caused some of you who worked in this room, it's working. We've covered 20 million more Americans, and those Americans now, for the first time, can go to a doctor and be able to not pay for it, be able to get access to specialty care, are protected from catastrophic economic disaster should they get sick. And so this is a good thing. Many people have Medicaid, many have commercial insurance. There's been net gain in employer-sponsored insurance, and so more people have health care through their work and take advantage of the tax deductibility of health care to gain access to health care as well. On the cost side, despite lots of worries that we'd have great inflation, we've had the slowest 5 years of cost growth in really distant memory. And we actually have premiums today, despite what you may have read, that are lower than the CBO predicted when we passed the ACA in the individual market. On quality, today when you leave a hospital with certainty, You will have a discharge plan, an appointment, and your medications. And that's led to thousands of Americans who haven't been readmitted for preventable things to hospitals and great attention and coordination of care. A lot more patients are on higher quality health insurance plans, and there's a lot more attention to data, evidence-based medicine, and treatment guidelines than we've had before, which is making us have learning loops to help us not repeat mistakes that we made in the past. Now, there are a bunch of things we can do to make the system work better, and so I'm going to talk to a few of those now. The 4 important policy priorities that we will all face for our next generation and the next Congress will also face immediately is how to make exchanges work better, how to make the markets work better, how to deal with the marketplace, so the hospital market pricing power in particular that leads towards upward price pressure without a demand side that can necessarily push them back down. Governor Leavitt talked about the new payment models. One of the central important parts of the ACA is the movement over the next decade from fee-for-service payment models where doctors and hospitals are paid for each thing they do to systems where instead they're paid a lump sum or a bundle or some form of value-based payment where they're rewarded for good outcomes at lower cost. How do we design those in ways that brings people in and doesn't create unexpected consequences? And then the last thing is, what do we do to save more money faster? Healthcare in America is crazy expensive. $15,000, or actually more than that, for a family of 4. That's nearly half of the median American wage. It's growing at 5% a year, which is the new slower growth rate. We have to make healthcare more affordable, or we'll crowd out lots of other important things in our economy that we don't want to crowd out. So we have to make the system more productive. So let me talk a bit about each of those for what you might do as policymakers to make these work. On exchanges, we should first remember that if anybody has bought individual insurance before 2014, it was a terrible experience. You sent in forms, you might have had to have a medical exam, you waited several weeks, then you got a mysterious price and you couldn't really ask questions. The policy might have a name, but it meant nothing to you, and all the details were in 75 pages of 10-point font that you couldn't understand. Today, when you buy insurance, you can go to a website which now works, you can select bronze, silver, gold, it says what the price is immediately, and you know what you're going to get. So it's a massively better experience than the old paper-based system we had before. That said, the market's not been as dynamic as one would have thought. We haven't built an ecosystem like Amazon or eBay where there's lots of choice and lots of competition and downward price pressure. So there's some things we can do to make that market work better. When we passed the ACA, we knew it would take a few years to have stability in the risk pools, get enough people in, get enough experience, and so we had some policies designed to stabilize the markets, and those were risk adjustment, reinsurance, and risk corridors. As you may know, there's been lots of contention over risk corridors, but my argument is that we should extend these 3 policies for a few more years to create stability in the marketplaces. Another topic where we had great debate, and I think a tweak could help, is something called age bands. Today, when a young person buys insurance versus an old person, there's a 3-to-1 ratio in those prices, which means that if you're older, you get a really good deal on your health insurance, and that's good. Older people have more healthcare costs, they're sicker, they need it more, and so you like to have affordable coverage for people who are older. The challenge is that if you're young, like most of this room, you're paying more than you did before. And so if you created a broader spread, you would have lower prices for younger people. That brings more young people in. That's good for the risk pool. It's good for America, I think. The downside is we'd have to do something, I think, to make policies assuredly affordable for older people, which would be a little bit more subsidy on the back end. The third thing, and this is economics 101, Professor Reinhardt would teach this on the first day in his class, is that larger markets are better. And so we set up in the ACA 50 state exchanges. And that's great because each state has some idiosyncratic differences in how they think about insurance and how they want their markets to work, but some of them are very small. And so larger exchanges are more attractive for people to sell policies into, so you'll have more competition. You'll also have more stability, because in a small pool, if a few people are sick, you can get lots of volatility in premiums. So we need to think about how to create larger markets, and that could be multi-state exchanges. It could be just changing the bidding areas for health plans so they bid on bigger regions. In California, we have several large regions plans bid on, and that's led towards actually good competition and choice and a system where the plans make money and premiums have not grown as quickly. The final thing that I put up below the dotted line, because I doubt that we're going to want to talk about this politically, is it wouldn't hurt to think about the mandate and subsidies, because part of the challenges today is that the penalties to not buy are not anywhere close to as great as the cost of buying for many, many people. Next topic I want to take a moment to talk about is hospital market power. If you think about healthcare, most of you will think about hospitals and the big buildings that they have on all those beds inside and the amazing things that happen in an ICU in a hospital. And they're very important. They do a great job for many patients, but they're super expensive. One day in a hospital costs more than $5,000 on average in America. $5,000. That's more than any hotel you're going to stay at. And in fact, for that much money, you could have me come to your house to take care of you for the day, and we would all be happy. Those hospital prices are growing between 5 and 10% every single year. There's no other price in the US economy that's growing as fast as a hospital price. The other problem is that unlike drug prices, which are easy to talk about, hospitals actually are a lot bigger part of the health economy. So it's about $1.9 trillion spent in US hospitals of the $3 trillion we spend, give or take. And that part of that slice of the pie, is growing faster in terms of total dollars per year than any other slice. We don't have any system to really create competition for hospitals. I mean, you have one, you go to it. Very few patients will drive far or fly to some other place to go. And so with that consolidation that we've had of hospitals often buying doctors and hospitals building bigger buildings and bigger markets, we've seen prices go up faster than any other part. This is an example of data from Professor Jamie Robinson, which shows you kind of the effect, but in markets where there's not much hospital competition, prices are 30 to 50% higher for everything. And that's problematic because you as a patient have a hard time shopping. And so some things that you could do to mitigate that market power and make the demand side have a bit more say here is the first one is there's been lots and lots of mergers since the Affordable Care Act of hospitals and doctors and systems becoming bigger systems. And these are all promulgated on the promise that this is all being done for you to make your quality better as a patient and your experience better as a patient. And it's true that in some places, integrated delivery systems have done a great job at that. We often talk about the magic of Geisinger Health System in Danville, Pennsylvania, or the amazing things happening up at the Billings Clinic in Montana or Kaiser in the West, and that you can get some great outcomes when you coordinate care with specialists in hospitals and primary care and computers and share data. But a lot of times what happens when you merge these systems is you raise prices first, well before you coordinate care and create better quality. And so one thing that would certainly help mitigate the pricing tendency to do these mergers would be to say above a certain threshold, hospitals should accept Medicare prices for all payers. So they can't just jack up the prices and wait a long time to make quality better. Another important policy is today, if you go get an MRI or X-ray or your colonoscopy screening for your cancer at a hospital, you're going to get 2 bills and one will surprise you. You'll get a bill from the doctor that does the procedure and you'll expect that bill, but you've got a second bill called a facility fee, which could be thousands of extra dollars. If you did that at an outpatient center, not at a hospital, you might get a second bill, but it would be orders of magnitude lower cost. And so today in Medicare and in most other health insurance, there's these 2 payments, site payments and then the doctor payments. If you made the sites neutral, you would create a lot more dynamic market because hospitals make a ton of money on those outpatient services. Third thing is that there's a bunch of patients that get access to special drugs called 340B drugs in hospitals. They can't get them on the outpatient side. That makes no sense. We could change that. The fourth thing is when the Justice Department and the Federal Trade Commission looks at mergers, they look at a big geographic area called a hospital referral region, which makes sense for the Dartmouth Atlas, but it doesn't make sense given the shopping radiuses that patients use to shop for healthcare. When we've looked at data, most patients use a 5-mile circle. They get all their health cares in that circle. Well, a 5-mile radius is much smaller than an HRR, which is like the entire Northern California Bay Area. And so we could use zip codes to figure out if we're limiting competition when we look at mergers. Then the last thing is, we have in the Affordable Care Act a requirement for not-for-profit hospitals every 3 years to do a community assessment for the value they create. And they write a report, and you can read them, and you should. And you'll be chagrined by the subtlety of the quality and public health benefits being created by many hospitals. So we need to actually have a way to kind of hold them accountable for like what they said they do around quality improvement. So those are some thoughts on how we can potentially make the hospital market more dynamic from a price, quality, and value perspective, and put pressure on the hospitals like every other product company has to make their product better every year. Next, I want to talk about payment models. This is data from the most recent CMS ACO data release on savings generated. And when you look at the savings generated by ACOs thus far, and I agree with Governor Leavitt, we're just in the knee of the curve of adoption here, and we're going to clearly have a lot more adoption of these models. If you look at where money's been saved, about half of the money has been generated in terms of savings by physician-led ACOs who are independent of the hospital. And that's not too surprising. When you're running a hospital, your job is to fill it up. When you're running an ACO, your job is not to use a hospital. And so there's tension in this model, right? The savings, this is a zero-sum payment system. The way it works is there's a benchmark for a Medicare patient. If we can take care of that patient for less than the benchmark, you either get half or more than half, depending on the model that you're in. That savings comes from hospitals, specialists, post-acute facilities, and most of it comes from hospitals. So not surprisingly, when a hospital runs an ACO, they have angst. They're not sure what they want to do because they lose revenue today to maybe get it back later in shared savings, but they share it with a payer. And so we have to think about that when we're designing alternative payment models, to design them in ways that we don't misalign the incentives at the front. The issue with fee-for-service is that we misalign incentives from the point of view of patients and those who pay because the current system pays for more stuff. In an alternative payment model, we have to make sure that we're aligning incentives with those who are delivering care such that they're better off if they perform better from a cost and quality perspective. Some thoughts on how you would design these are the following. The first is the ACO program is Don Berwick would often describe it as an escalator. You get on and then you can move up in complexity and risk. Most people today are on one-sided risk, which is basically a very good bonus payment program. So if you don't save money, you get paid whatever you get paid. But if you do, then you'll split some of the difference with Medicare and you'll get a bonus payment at the end. And that's a good way to learn, but you don't redesign your system of care completely and adopt technology and think about it from the point of view of a patient and how you would engage them successfully in the fullness that you need to without eventually moving to a two-sided risk model. So I believe there should be a duration and a graduation to more risk as we think about this policy. The next issue, particularly for independent doctor groups, is that you can lose much more than you were paid by Medicare today. If you're in a two-sided risk model today, a primary care doctor might be getting 5 or 10% of all of the revenue of the patient, but they're on the hook for 100% of the losses. And so they could lose a lot more than they were paid, which makes it hard for groups that don't have balance sheets and reinsurance and a bunch of capital to do this. We should think about how to cap losses for those that don't have access to the rest of the money so they can afford to be in these two-sided models that I suggest that they should be in. The third thing, and this is something that when we created the ACO program, we had a lot of discussion about and a lot of angst from doctors, is that the way it's currently designed is that you have a 3-year benchmark, and then you do your 3 years. And then the next 3 years, you reset to however you did before. So if you did a great job at saving money in the first 3 years, your new benchmark will be reset at your new kind of lower price care, and then you have to beat it again. And maybe you can, because there's a lot of improvement opportunity in healthcare. But over time, you're racing against yourself, and that doesn't make a lot of sense to sort of keep saying to the best providers, get better. And so we should think about readjusting to the market averages or some other benchmark after the first go-round. Then the last thing that's amazing is the rate at which upcoding occurs in our healthcare system. And in every talk that everybody all policy talks, we always have a line saying, let's root out fraud, waste, and abuse in U.S. healthcare. And we all say, of course we should. But the most egregious area is actually in the coding system. So we all passed ICD-10s to get more specific so we can be better at being sure that the patient's coded accurately. But the real way this works is you give patients more diagnosis, more codes, and that's how you get paid more. And it is breathtaking how quickly you can take admissions out of hospitals and then see the patients that are left over suddenly appear sicker in codes than they appear in reality. Examples are patients who used to be treated in hospitals for urinary tract infection being coded as sepsis. That's a $40,000 difference. It's the same treatment as IV antibiotics for 3 days. And so this subtlety in how you code has massive effects on how much you save. And today we don't have a good system to actually hold anybody accountable for this. And the Medicare RAC audits are one-off, one at a time, and not systematic enough to actually protect against this. In the Medicare data every year, you might see, those of you that read the inpatient rule, a line called coding intensity adjustment. What that means is actually adjusting for coding, upcoding, which reflects patients aging more than 1 year in a year by virtue of the codes they get. We need to think about how to adjust for much more coding intensity in the future. The last thing I'd add, and there's been a lot of discussion about this, is having some system where we can actually reward patients for engaging in their care. One of the most important healthcare measures is actually something called patient activation measures, a PAM measure, which talks about how active is a patient in knowing what their outcomes are and knowing why they're taking their meds and wanting to go follow up their visits done and sleeping and walking and doing all that stuff that we tell you to do before you leave my office. And the more I can get a patient's eyes to light up and care, the better they do. And not enough time is spent in American healthcare actually making sure the patient actually knows what they're doing and why. But when that happens, better outcomes occur. And so having some mechanism to reward, whether that's through cost-sharing differences or other things, would be important mechanisms to making these new models work better, because they require cooperation. The last thing I want to touch on for a moment is, what should you do to bend that cost curve down? What are the next set of things to do? The first thing is labor productivity, and this is a tough one. America loves middle-class jobs, jobs with benefits, jobs that pay well. Healthcare jobs have been good jobs, but we're hiring at a rate that's faster than demand is growing. And the most expensive thing in healthcare is actually the labor, the people. So for every doctor, there's now 16 FTEs running around in the health system, 9 of them are administrative. The number of non-clinical labor jobs has doubled in the last 20 years. That's the opposite of what you'd expect in a system that's getting more productive. Usually the ratio of non-productive to productive labor gets smaller every year as we get more efficient. We aren't seeing that yet in healthcare. So we have to think about how to simplify the administrative processes and how to redesign them to have, frankly, fewer people in them and more reliability, so you don't have to check and fax so many things back and forth. I believe we should tackle medical malpractice. We haven't tackled it yet. Whenever I talk to doctors, the first 7 questions are versions of, why don't we fix medical malpractice? It's leading towards at least angst and perhaps some defensive medicine by doctors. I think there's lots of things that one can do to make it work better. I favor actually rewarding doctors for following evidence-based pathways as one mechanism, but there's lots of ways you could do it. And then the last thing is we have to think a lot about substitutes for hospitals. They're super expensive. We need to figure out how to do payments for care at home, how to reward doctors for using their offices for things that they would have used the ER for, to create competition on the supply side. I want to leave you with the following 4 benedictory comments. The one is, despite lots and lots of discussion and angst and the worst website launch in the history of the internet, the ACA is actually working. When you walk around to hospitals, insurance companies, patients, you see change. There's millions of people now who have access, who are experiencing technology, who are seeing systems that care differently for them. It's working. The next thing I'd say is exchanges are a good idea. They can work well. They require some tweaks, I think, to make them work better and make them more dynamic. But I don't think anybody wants to go back to the old way we bought insurance and underwrote it. And so we can make them work better. Cover California is a shining light for how you could make this work, and there's a lot I think you can extrapolate to other exchanges. The third thing is, the problem is cost. If healthcare cost a lot less, we'd have a lot less angst about getting people into the markets, right? If healthcare was as reliable as any other product you bought, if it were more than 1 sigma for quality, we'd have a lot better adoption of the product and people would want to follow through with it more. And then the last thing is that the policies that we passed over the last few years, the ACA, the High-Tech Act to wire us all together, and MACRA, as Governor Leavitt said, are monumental. They definitely have moved everybody from the old model to a new model. We're early in the adoption, but that new model will be one that cares a lot more about your outcomes, engages you more, thinks about it from a product perspective, and leverages technology in all the ways we have in the rest of the economy to make it work better. So I'm very optimistic for the future. I thank you for your time and attention.
Now it's my pleasure to introduce our next speaker, J.D. Hickey, who is President and CEO of BlueCross BlueShield of Tennessee, a nonprofit health plan serving more than 3 million members. J.D. has an unusual background for a health plan CEO, having previously led Tennessee's Medicaid program known as TennCare. Then Governor Phil Bredesen tapped J.D. to turn around TennCare and control the soaring cost and try to preserve the coverage. J.D. led that effort successfully, and I think is very proud of the work that he did on that. Prior to that, J.D. was a consultant, was a partner with McKinsey and Company. He continues to be a champion for the residents of Tennessee as CEO of BlueCross BlueShield, and we're so pleased to have him with us today. J.D.?
Good afternoon. So I've got the privilege of telling you about Tennessee's new Employment and Community First program. Before I do, I just want to give you a little history, a little background in Tennessee on why this is so important. So there's a number of reasons why, when we think about the future of healthcare, we should be focused on the highest cost populations. So one of them, obviously, is that's where the money is. If you look at Medicaid, that's now a 70 million person program. It's the largest federal health care program by enrollment, over $350 billion worth of expenditures. But if you look at it, you've got 20% of that population, less than 17 million people, who are responsible for 70% of those expenditures, about $245 billion. And it's that senior and disabled population in the middle. The second reason to focus on these populations, particularly, by the way, if you look at the two top bars, when you talk about the institutionalized group, the efficiencies are so high, the spending levels are so high, it gives you lots of room to innovate. You can provide a lot of hands-on care in a small setting and stay below that $106,000 benchmark. The last reason, and probably the most important one, is healthcare is one of those perverse industries where our most loyal customers, our biggest, highest spend individuals in any given year, are also our least satisfied. And it's not because they have health needs, it's because the quality of care is so low. And if you particularly talk about the Medicaid institutions, the care levels in some of those have been so low for so long that you've got people demanding and asking for change literally for decades. So I'm going to take you back in time. I'm going to go back to 2006 in Tennessee. This is a Medicaid program that simply wasn't focused on home and community-based services or long-term care at all. It wasn't that they didn't pay for them. They did. They had for years. But accessing the services was so difficult, and the services were so piecemeal, it just wasn't enough, obviously, if you look at the data, to overcome the natural profit drivers that were sitting out there in inpatient and institutionalized care. I can be hard on this program and this leadership team because I was Medicaid director in this window, and it wasn't that we didn't care, it wasn't that we weren't aware, but we had so many other things on our plate, we simply, sadly, weren't capable of the systematic, comprehensive reform that this type of spend pattern demands. I will tell you a telling aside, it was early in 2006 that we got protested by ADAPT, rightfully so. Again, if you look at the numbers, that's a disability rights protest group. They actually came and handcuffed our doors and locked us into our building, and I can remember looking down from the fourth floor with my management team as the protest group paraded in front of our group, and they were dragging an effigy of our long-term care director behind one of the wheelchairs. And about the time they lit it on fire, my long-term care director saddled up. My recollection is we never made eye contact, and he leaned in and he said, "JD, I put my resignation on your desk." And I leaned back and said, "I think it's about time." And I've often thought there's no more pure example of democracy in action. Thankfully, there were people who were capable of that systematic structural reform. It came after I left, but the long-term care director who followed that individual, his name is Patty Killingsworth. She's still with the Bureau, one of my personal heroes. She came up with choices. What makes choices so unique is that, or was certainly unique at the time, it was a systematic, comprehensive set of HCBS benefits integrated that was available statewide. It had a single point of entry, and importantly, it was all managed through a managed care structure that was fully incentivized, fully capitated, with a really strong financial incentive to try to keep people out of institutional care. If you flip forward to 2014, you can see the dramatic results that are in the data. And this is a national story to a degree. I believe 2014 was the first year where HCBS overtook institutional spend overall across the nation, but no state improved as fast or as dramatically as Tennessee. And I will tell you, as a managed care CEO, we were not good at this at first. If you think about the skill set required, it is as fundamentally different from claims adjudication as you can possibly get, but it is a core competency for us now. We've got hundreds of nurses. They don't do anything except work out of members' homes. They provide meals. They do wellness checks. They oversee home modifications. They provide pest control services. And if you think about the demographics, if you think about the geography of this program in Tennessee, we've got nurses going into some of the toughest neighborhoods, some of the most remote geographies in Tennessee, and together, collectively, I'm very proud to say that we're changing lives for the better. You'll also notice we're saving money. For those of you who saw the quick hit math, the total long-term care spending budget from 2006 to 2014 actually went down by $12 million. excuse me, that's not typical for a federal healthcare program, as you can imagine. Over that same window of time, the TennCare budget went up by 50%, and I think the enrollment went up by 15 to 20%. So it's a tremendous accomplishment.
I've always had that nurturing personality, and I just feel like that I've been blessed with being able to serve others and letting them know that I'm there. It's great to know when we've made a difference in someone's life and that it's made a better place for them, because a lot of our people that we see are in a bad situation sometimes, and sometimes we can change that. We go out to see these members in their home, and we sit down and visit with them and just make sure that they're getting what they need. They get to feel like you are their family, because we may be the only visitor they have outside of our provider. Each and every time we see them, we encourage them to let them know that we think they can get better. And I'm sure that that gives them a peace of mind. To see that they are living a better life and to see the relief in the members and their families' faces is priceless.
Looking ahead, the same rock stars in the TennCare Bureau who came up with the Choices program have come up with a new program, Employment and Community First. These are for individuals with intellectual disabilities. These are individuals who have a serious cognitive impairment. It's been present since infancy or birth. And in Tennessee, most states have an asset requirement. In Tennessee, it's $2,000, and you can think about that number for a minute. We've got over 6,000 individuals in Tennessee who meet those criteria, who've been on a wait list for services, in some case for decades. That's not unusual. Nationwide, that number is probably somewhere above 300,000 to 400,000, and that's of the intellectually disabled that we know about. By some estimates, over 50% of people who meet those qualifications aren't known to the state system, and if you think about being on a wait list for decades, you can understand why. There's a couple of things that really make this story even more pressing. One is the majority of these individuals live with a family caregiver who's going to age beyond the capacity to provide care over the next 10 years. And it's estimated that 2/3 of those families don't have a plan in place for what happens when that primary caregiver passes away or becomes incapacitated. Another real pressing part of this story is the lack of employment opportunities, which is core to this program. Over nearly 70%, of the intellectually disabled are unemployed. That was true in the 1970s and 80s, and sadly, it is still true today. The way the current system works in pretty much every state is the only way to get off a wait list is to have a crisis, usually culminating in the emergency department. If you think about that, that is a setup for institutionalized care. The good news, by the way, one of the silver linings here is most states over the last 10 to 20 years have shut down their big state-run institutions. We've got 30 years of very good data that says individuals are happier, they're healthier, they report more control over their lives if they live in a smaller setting. But being placed in the community is not the same as being part of the community, and having meaningful employment is a big part of this. I won't go into detail, but the program is structured around 3 tiers of support. We've got waiver approval for 1,800 individuals in the first part of the program. There is a specific part of the program that's tailored specifically for those developmentally disabled who are coming and graduating out of the school system. If you think about it, that's a particularly dangerous time for many disabled as they disappear from the system entirely. A couple things I will add. If it seems expensive to provide tens, if not hundreds of hours of home-based care, remember that $106,000 institutionalized benchmark on the first slide. The other one I would say is this is great work. We are privileged to be a part of it, but this is not charity work for us. This is big business. This is a new program, but the Choices program that I talked about a minute ago, we've got revenues well over $500 million a year. We earn a very respectable margin on it. It's a very important part of this story being as sustainable as it is. I'm going to close with a profile of Ryan, his grandmother, Kim, and his care coordinator, Kristen. Ryan is one of our first ECF members. He lives in Red Bank. He's an Olympian. He has 2 jobs. He works in a grocery store and at Walmart. What does he want? He wants a promotion. He'd like to get paid well enough in one of these jobs that he doesn't have to try to juggle 2 of them. He'd like to date. Ryan would like what we all want. Ryan wants what we all want for our families.
I was on a wrestling team through high school. I was a part of I was a football manager for my high school too when I was in school. We had a Lord Ray Smith golf tournament, and it was a full men's select shot, which I ended up having my own team, which was me, my dad, and one of my friends and his partner. We came in first place in the third flight. They say I work hard, that they wish there was more people out there that was like me, that would be able to work like I do. Being able to drive, getting a promotion at work, and being able to get out and get my own place. I'm wanting to live out on my own, where I can meet other people around my age. Maybe dating after I get used to driving. I want to be treated the same way other people would like to be treated.
And this is Kristen. Kristen's one of our new employees. She's a 20-year experience as a family care supporter in the intellectually disabled community. If you think about it, we've got 6,000 people who work for Blue Cross of Tennessee. We're really good at wellness. We're really good at claims adjudication, but we don't have anybody, or we didn't before this program, who fits Kristen's profile. If you check back in with us a few years, I think we're exceedingly optimistic. This is going to become a core competency for us. It's going to be big business, but most importantly, we hope to change lives and save some money. Thank you.
Now it's my pleasure to introduce Jeff Rowe. He's president and CEO of Premera Blue Cross, the largest health plan in the Pacific Northwest, serving 2 million members in Washington State and Alaska. And Jeff is leading the transformation of Premera to a consumer-centric company. And as you'll hear, he has a unique perspective working with large, innovative West Coast employers that you know their names, Amazon, Starbucks, and Microsoft, to name a couple, who have transformed the customer experience. And so he's bringing this consumer-obsessed culture to healthcare to make it easier for Premera's members to understand their healthcare benefits and navigate their healthcare options. And Jeff actually began his career here on Capitol Hill in the office of Senator Slade Gordon from Washington State. So we're delighted to be welcoming him back to the Hill today. Jeff?
Good afternoon. Thank you. It's great to be here with you and to be a part of this important discussion. This is really an esteemed panel. I'm honored to be a part of it. So you've heard a lot about healthcare policy today, and I think the insights that Governor Leavitt, Bob, and JD have provided thus far have been really excellent. As we move this discussion forward, though, I'm going to move in a slightly different direction, and that is to step way outside of the box of policy and examine the issues from a fresh and totally different perspective. As Nancy just said, I spent 4 years on Capitol Hill, and I found one of the great values that I benefited from was when an outsider came in and actually shared a perspective from a place other than Washington, some that might call the real world. So I'd like to talk about 3 Seattle-based companies that are well known throughout the world for the tremendous success they've achieved in 3 very different industries. Success that's been driven by technological innovation, by operational excellence, and perhaps most importantly, by providing a great customer experience. And they are, as Nancy said, Amazon, Starbucks, and Microsoft. I'd assert that there's a lot that we can learn about the potential future of healthcare from these companies. And all 3, by the way, are clients of Premera BlueCross. So join me for just a few minutes as we consider these questions. What if Amazon, Starbucks, and Microsoft ran healthcare? What kind of system would they create? So let's start with Amazon, the first of these. We have served as Amazon's health plan since 2012, so we feel we know them fairly well. Amazon, first of all, is obsessed with its customers. They have worked relentlessly to put the power back into the hands of consumers. They are an organization that makes decisions based on actual data, not pithy anecdotes, but hard statistical evidence. And they combine these 2 great obsessions, customers and data, to deliver an unequaled customer experience, one that makes every interaction with their customers simple and easy, fast and integrated. So at Amazon, as you know, you can buy just about anything in the world in an environment that is all about transparency. Amazon customers are given information they need to compare products by cost, by quality, and by user reviews, thereby helping the consumer to make purchases that's right for them. You can get really low prices at Amazon, but you can also pay more for products that provide superior quality and value. The choice is yours. And they do all this without requiring their consumers to do much more than to simply access the internet. The product does the work, not the consumer. So this dynamic makes Amazon suppliers compete and compete aggressively. Bob brought this point up as it relates to healthcare. So let's contrast this level of transparency, which is so fundamental to a well-functioning marketplace, with what consumers are subjected to in healthcare. Prices are completely opaque. The consumer leaves a provider and later opens an envelope with an explanation of benefit in it after the fact of what the service cost. As one person remarked at Premera, there's a surprise in every envelope. Reports on the quality of care are highly complex and confusing. Providers compete mainly on the basis of their brand name and the convenience of their location, not on service excellence, and certainly not on the quality of their outcomes. That lack of transparency permits dramatic variation in cost and quality in the delivery of health care, something that a well-functioning marketplace would never tolerate. In Washington State, we have providers who charge 30% more than the market average, even for basic routine services with quality that is just average, if that. It's simply not justified, and yet provider reimbursement rates often are presented as a take it or leave it proposition, particularly in those concentrated markets Bob highlighted. So in essence, you pay more and you get less. In any other industry, consumers would never tolerate such treatment. So a competitive and transparent marketplace wouldn't sustain such significant differences in prices for any services. Another thing about Amazon, a customer phone call there is considered a defect. Think about that for a moment. If a customer feels the need to call Amazon to discuss an issue, Amazon considers that a defect because Amazon has failed to provide a process that is seamless and simple enough for the customer to not need additional assistance. And yet, if a so-called defect occurs, Amazon is available immediately to help the customer get the issue resolved. So in contrast, at health plans today, phone calls, including my health plan, by the way, phone calls are the primary way consumers get questions answered. Amazon's so-called defect is our primary mode of interaction. And as an industry, we still use paper, forms, prescriptions, and so forth. So let me say that again. It's 2016. I think this is important, and we still use paper and fax machines in healthcare. It's unbelievable. If Amazon ran healthcare, I believe we'd see an integrated marketplace platform that would seamlessly and easily connect patients with the right providers, giving patients the objective cost and quality information they need to make an informed decision about the care they deserve. So I ask, is this all a bit just too conceptual for today's discussion? And I don't think it is. And I say that because at Premera, we've already started this process of trying to behave like an Amazon. So let me give you a few examples of how this kind of thinking is transforming our approach to healthcare right now, today. So as we all know, navigating healthcare is too darn difficult. It's complex, it's confusing, it's burdensome. In response, at Premera, we've developed an innovative new tool called Decoder Ring. Decoder Ring, like Amazon's Echo, which you see here on the screen, simplifies the process immensely. With this new technology, our customers can use their mobile device or the Amazon Echo to ask questions like, is my knee surgery covered? What will it cost? And immediately, they get an answer. No more phone calls or trying to wade through a dense, virtually unreadable benefits booklet that has been the norm in our industry for decades. The other thing about Amazon is they're really customer obsessed. It's amazing to walk through their ecosystem. You can feel that pulsing through the environment. We in healthcare need to adopt that customer obsession. I went in for a procedure not long ago, pulled into the facility's garage, and encountered a sign reading, "First 2 floors reserved for doctors." That's not patient-centric. And by the way, that's not unique to that facility. So at Premera, again, we've launched another service called Premera Listens. In fact, it was developed by a former Amazon employee who now works with us. Premera Listens allows us to quickly make improvements to our service based on real-time online feedback collected from our consumers. And perhaps the best part of the entire project is it went from concept to launch in 4 months, which at Amazon is normal, but in healthcare is light speed. So as we look ahead at Premera, we're designing products, networks, provider compensation models, analytical tools, transparency capabilities, and so forth, all with the intent of creating a more competitive environment where providers actually have to earn consumers' business. If Amazon ran healthcare, I believe that's what they'd do, and that's what we're trying to do at Premera. Let's turn to Starbucks for a moment. They've been a Premera client since 2009. So here's a company that sells a commodity at almost twice what others charge. We all are subject to that. So how do they do that? So, as most would say, they sell an experience, not just coffee, right? They offer a familiar place, a warm, inviting environment, an atmosphere where there's likely an emotional connection, and a quality product made to your exact preferences. At Starbucks, I've spent a lot of time down at their headquarters, they talk about the third place their stores provide. There's work, there's home, and there's Starbucks. And people pay a premium for that experience. It's what's behind the experience, though, that most impresses me about Starbucks: operational excellence. They've made a science out of running their stores with an extremely high level of efficiency. Yet because of their emphasis on the customer experience, you rarely hear the company discuss operational metrics. Contrast that with most health plans. Again, Premera is in that group. We focus on metrics like average speed of answer or claims turnaround times. You'll probably never hear Starbucks talking about grinding beans in 30 seconds or less. And yet we hang our hat on that every day. Yet without this foundation of operational excellence, Starbucks could not produce such a predictable, high quality, and yet personalized experience. You can get your cup of coffee at any Starbucks anywhere in the world, and the experience will be exactly the same every time and in every location. The only thing that may differ is the languages spoken. Now let's compare that to healthcare. When healthcare works, when lives are saved and well-being enhanced, the experience can be nothing short of amazing. But too often it's just okay at best or maddening and frustrating at worst. A major driver behind these dichotomous experiences is the major lack of standardization. The variation in care patients receive is tremendous. Take cancer care, for example. It isn't unusual for cancer patients to seek a second opinion. And most of the time, they'll get exactly that, another completely different opinion. This will often occur even with two doctors in the same institution. For a health condition rife with such emotional and physical burdens, patients should not have to struggle with the confusion that leaves them wondering if they're truly getting the best therapy for their problem. So as part of the future we envision at Premera, we're working with the Seattle Cancer Care Alliance, comprised of Seattle Children's, the University of Washington, and Fred Hutchinson Cancer Research Center. They're international leaders in cancer care, and we're working to ensure that our members get consistently the best care recommendations for their particular form of cancer from a team of true experts. And along the way, we're partnering with those institutions to provide Premera members with an advocate who will ensure that all of the patient's care needs are met in a way that suits them. That way, they and their families can worry less about the process and focus more on themselves and their own well-being. Standardized, yet personalized healthcare, Starbucks style, we would contend. Another area in which Starbucks excels is convenience. They have more than 24,000 stores worldwide. Starbucks is practically everywhere. In a sense, they bring the Starbucks experience to you. If Starbucks ran healthcare, I'm certain they'd make healthcare more personal and convenient as well. The act of providing care to patients would be the same no matter where the location, but the experience would be tailored to each individual's patient's needs. That's what we're starting to do at Premera. For our members with the greatest need, the 5% of our members who account for 50% of the cost, JD highlighted that in his remarks, we partner with a special team of providers who bring services directly to those patients in their homes and on a schedule tailored to their needs. Doctors, nurses, behavioral health specialists, all of them are ready 24 hours a day to help our sickest members get exactly the care they need when they need it. That's what convenience means in healthcare. And what that convenience translates into is a better experience for the patient that also happens to provide higher quality care at a total lower cost. So I hope from there you could see it's easy to imagine a future where patients visit a brick and mortar hospital only for trauma or for surgeries, while all other care is conducted in the home, online, or at convenient neighborhood locations. So finally, my third company to profile here is Microsoft, a company that Premera has been privileged to serve for more than a decade. Not only do we provide their health coverage, but we actually maintain an office on their campus where their headquarters is located in Redmond, Washington. So we're literally a part of their unique and very powerful culture. So I think Governor Leavitt had a quote from Bill Gates. I'd like to share one as well. When I think of Microsoft, I think of empowerment. So over 40 years ago, in 1975, Bill Gates famously said his goal was to put a computer on every desk and in everyone's home. In achieving that goal, Microsoft-powered computers have made consumers and businesses vastly more productive and efficient. In my view, healthcare needs a Microsoft-like movement right now, particularly in developing tools that enable better decision-making and better delivery of care. In healthcare, we're buried in data, yet in many cases, doctors lack the information necessary to empower them to clearly understand their patients' needs. So we're not Microsoft at Premera, but we've built a pretty sophisticated tool to integrate and analyze a patient's information to dramatically improve the care they receive. It's called OneView, and it aggregates all of a member's claims and medical information from the EMR, reviews it for consistency, and analyzes any gaps in care that may exist, like prescribing irregularities. It then presents that critical, objectively analyzed information digitally at the point of care, that is, to the doctor in the exam room. This powerful interpretive tool eliminates the potential problems that can arise when a patient's care is fragmented among a variety of providers. And it gives each of them a complete view of that patient's history. In the process, it thus empowers to provide the best possible care possible, driven by the power of technology. So in conclusion, I'd say this. Amazon obviously doesn't run healthcare and probably doesn't want to. Starbucks and Microsoft probably feel the same way. But the fact is, healthcare needs these awesome companies and needs the same kind of transformation that they brought to other industries. I think as you're hearing today, and hopefully have from me as well about Premera, many BlueCross, BlueShield plans are working to make that happen. Thanks very much for your time.
Now it's my great pleasure to introduce Uwe Reinhardt. Uwe, as many of you know, is the James Madison Professor of Political Economy at Princeton University, where he's one of the most popular and respected professors. He's a prolific author and an original thinker. Uwe has served as an advisor to the Clinton White House, maybe again, the World Bank, the Physician Payment Review Commission, now known as MedPAC, the VA, HHS, and many others. He continues to inform policy and the public as a frequent speaker and a guest blogger for Health Affairs, JAMA, and also appears in the New York Times. He's NIHCM's longest-serving advisory board member, and it's just really been my great pleasure to be working with him for over 20 years now. Uwe?
Well, Nancy always makes sure to have a skunk at the garden party, so that's my role. I want to talk about value, because what I learned from the speaking circuit and the blogosphere is that we're moving from whatever we were doing towards value. That's the future of American healthcare. Now, it's true if you reached my age, we've always had some mantra by which we marched. In the 80s, it was the pro-competitive strategy. Remember that? We deregulated everything, and that was supposed to control healthcare costs and improve quality. It did the opposite, but we marched for it for a decade. Then came managed care in the 90s, and everyone was in managed care. But we read from the Institute of Medicine that 30% of American healthcare is a waste, so managed care must have had some limits in doing it and in doing what it's supposed to do, and now it's value. Now, my wife and I are both immigrants. English is not our mother tongue, and it's natural for an immigrant to inquire into the meaning of English words. We all do that as immigrants. Now you can just look it up, but we always have an iPad at breakfast to look up all these words. So that leads me to this talk. So if you, well, I've said these things. So when you go to the conference circuit, you hear about value-based health insurance, value purchasing, value pricing, value maximizing, innovation for value, the value chain in healthcare. And then you could make your own concepts. You can put any noun in there. Value integration sounds good. Value paradigm, always good. I like value inversion. I haven't a clue what that means. However, like any professor, I could probably give a good 45-minute lecture on the topic. Nancy, maybe next year I'll do that one. I saw this on the web because I wanted to look up what is the value chain. This is it. You find this on the web. I haven't a clue what this means. The people who drew it didn't either, obviously, but they thought it was worthwhile putting on the web. The patient isn't even in there, as you may notice. This is not patient-centered. I'm thinking of a conference called Value Valuing. Because if it is really true that so far we'd never moved to value in healthcare, we should be taught how to value. And you could have a good conference around that. Here's some clues. So I sort of went back, because I'm an economist, and we concern ourselves with value a lot. It's really about half of what we teach people. So when you actually do that, it goes back all the way to antiquity. You will find in the Code of Hammurabi, which is a stele and it's chiseled in there, 1700 BC, you will find a fee schedule, and it's value-based. No, there is a fee schedule, and it's value-based, and it said if the Babylonian patient is a nobleman, he has so many shekels. If he or she is a freedman, it's cheaper, lower fee, and a slave, even lower, much lower fee. Now, the interesting thing when you sit back and say, what a weird fee schedule, and then you look at New Jersey, that's exactly how we price pediatric care. If you're on Medicaid, you get $36 as a pediatrician. If you're commercially insured, it's $120. It's the Hammurabi Code. So some things last. Canada doesn't do that, by the way. Plato and Aristotle wrestled with this. Adam Smith, David Ricardo, all of these great guys in the 19th century wrestled with it. And now, of course, we know the answer. We teach it correctly. But they had it wrong. They made a distinction, Aristotle did, and should have, between value in use, what is a thing worth to me or to you, and value in exchange, how much money or other stuff do I have to give up to get this thing that I want. It's another word for price. And Aristotle and Adam Smith, all of these people could not really figure out why are there two concepts of value and how do they relate? Well, actually, it's nowadays quite simple. If you've all had this, Econ 102, if not, shame on you. We have a demand curve, which is really the value curve. Those are the maximum bid prices different consumers would bid if push came to shove. And then you have a supply curve. And where the two curves cut, that's value in exchange, that's price. But up there I have Jones' value in use. Jones would have paid a lot more for this thing if push had come to shove, say on eBay, but because you can go to Macy's, you get this stuff cheap. Generally, I've never bought a shirt that was actually, where the value in exchange was equal to my value in use. Because usually you go there and they say, oh, it's on sale. I didn't know. And you get 20, 30% off, but you would have bought it at full price. And that's a surplus. It's a psychic profits consumers get, which is not taxable, which is one of the, I think Donald Trump would like it. What complicates value in healthcare is that very often the people who get a procedure, like an EpiPen or any procedure, are not the people who pay for it. And there's a real difference there. What is something worth to me, and what is it worth to me that somebody I don't even know, who might even be in jail, gets it? Salvati is such a case, So it's very, very complicated to know what does value actually mean and whose eyes should actually be making that determination. Do you ever think about what does that actually mean? Even with the Salvati, that really came up because most of the people benefiting from it were actually poor people who couldn't pay for that. So there, any such drug, you run into this problem. Now we have management consultants who know the answer to things professors don't, which is why they can charge so much. And when you read what they say, is the following. They say value equals outcome over cost. And when you don't think about it, which is always a safe thing to do, that makes sense. But when you think about it, and when you're an economist, you say that doesn't make sense, because costs never figure in value. What something is worth to you is independent of the cost. You never ask, how much does something cost? You buy a painting, do you ask, how much does it cost to make this thing? You buy EpiPen. You never do costs enter value considerations in economic theory. And yet these management consultants make a ton of money selling this. One is, the outcome is, of course, multidimensional. You know, you can eat, you have an appetite, you can play golf, you don't have pain. That's multidimensional, but we can solve that. By the way, I would say, Harvard professors, this book, Redefining Healthcare, Michael Porter, he has it right on page 5, that value is outcome over cost. That's where I get this idea. Right there, I'm quoting it, page 5 of the book, and the whole book is about value. Now, one of the problems, this multidimensional thing, we can solve this by converting outcome into quality-adjusted life years. If you don't know what this is, I mean, basically it says you have an extra life year, but it may not have a high quality. How many, supposing a procedure gives you 10 more calendar years in a not great health status, and then you ask people, how many years of that life would you give up to have only really healthy years? And if that person says, well, actually, I'd give up 3 years to have 7 really healthy years, then that life in a less than perfect health status is quoted as 0.7 of a healthy year. That's quality. So this is a concept, one-dimensional, that can take quality of life and life expectancy into one number. So you could solve this problem, and I have that on this slide. I just explained. So it's basically value. This is the management consultant's equation. Value equals the number of qualities a procedure yields divided by the cost of that procedure. Are we now happy as economists? The answer is no. We're always complaining. My second problem is that cost shouldn't be in there. And what you could do with this, we go by the Latin dictum, res tantum valet quantum vendi potest. I don't know if the Romans actually spoke like that, but that's all I can do. This thing is worth what you can sell it for, which is, again, cost isn't in there, right? Whatever I can get for something, that's what it's worth in the market. So let me now turn this expression around and put it on its head. In economics, if you don't know what something means, invert it. See whether you can see what it means something then. Well, if you actually do that, you get what is known as the cost-effectiveness ratio, which people who do technology assessment use, which is what is the cost per additional quality a procedure buys you? Which is, all I did is take the management consultant's definition and put it on its head, inverted. And when you do that, imagine a procedure that gives you 3 additional quality-adjusted life years, but it costs $150,000. Now, 10 years ago, you would have said you're dreaming. Nowadays, that's a normal thing, right? That could be a specialty drug that costs that much. What does that really tell you? So is that value? I would argue, unless I know what a quality is worth, this expression doesn't tell you anything at all. What do you do with it? If I now turn it on its head and make it the cost-effectiveness ratio, then I learn that per quality, this procedure cost me $50,000. Does that tell me what a quality is worth? It doesn't. It tells you what a quality costs. Whether or not you want to do that procedure depends on what a quality is worth. In the US, we'd absolutely do it, but in some poorer countries, they would say, we're not going to do that. Even in England, they might harumph about that one. So the management consultant's definition of value tells you nothing about value. That's the sum of it. You can sometimes use it that if two procedures had the same cost, but one gives you more qualities than the other, you could say the one with more qualities is more valuable, but you don't know how much more valuable because you don't know what a quality is worth. And we Americans, if I asked in this room, what is a quality worth? I really should, just to torture them. You wouldn't be able to tell me. First you'd say, is it mine or is it someone else's? Is it a Democrat or a Republican? In this town, surely you would ask these things. And yet, I don't want to dwell on this so much, but there were these doctors who wanted to use that expression to say what is a high value and a low value procedure. And I say these doctors are just dead wrong. They shouldn't even get into that. In fact, they shouldn't listen to management consultants on this point. Now, why are people confused? Well, the management consultants actually are thinking about a process of comparing cost to value. They don't define value. They just think about how would I go about this, as I just did. Two procedures, same cost, different qualities, or two procedures, same qualities, but lower costs for one. That's what they're thinking of, but it's not value that they are giving you. The real problem that we face, and the next one I think I will click over, what we really like to know is the net value that a procedure gives you after costs. That's what these consultants are after. But again, the best way to explain that to you is to talk about the quality supply curve. The healthcare sector basically tells the rest of society through the insurance companies, saying, we can buy for you additional qualities that someone gets. Some are very cheap, immunization for kids, a lot of that stuff. Some are very expensive if you go Salvati, or even more expensive for cystic fibrosis. A drug costs $300,000 a year. And you get a curve like this. Of course, if you're not on the curve, you're inefficient. That is, of course, what the insurance companies now try to do, to get us onto that curve. But once you're on it, should you go from B to C? So you get a few more qualities, but they cost you a bundle, they cost a lot. Should you do that or not? And the healthcare sector says, this is what we, the health sector, can do for you, the citizens. Where do you want to buy on this curve? And where will you tell us, we're not buying anymore? In England, they say this is about $50,000. After beyond that, they complain and say, maybe we won't cover it. In the US, we can't even discuss this topic. If you do, people really get angry at you. I tried this once, and it was in testimony, and I really got blamed for that, the blasphemous, to even talk about what a quality might be worth. We have swept this under the rug and so far paid for everything. And that is one of the problems with what we now face with the specialty drug industry, since we don't ever want to discuss what the value of a quality is to us. Therefore, we can only pay for whatever they charge us. Because if you refuse, you will reveal to us your value, or the maximum value you assign to human life. If we had said, Salvati, no one at $1,000 a pill gets that, you would have immediately revealed the valuation you put on human life. And that's what makes this so difficult. Now, finally, we come to this concept of value-based pricing. And that, of course, I guess we talked about this. There are several concepts of value-based pricing. One of them, people who talk about it mean we're not paying for junk. We're not paying for stuff that's harmful to patients. We're not paying for stuff that doesn't do anything, and we're not paying for stuff that's only marginally beneficial. However, we will pay extra for superior quality. That's what the insurance industry now is trying to do. The second one, used by the drug industry, is saying, if we actually, you're already spending money on an illness. If we come in with a drug that's cheaper, the value added is the difference between the cost you're already incurring and what we can deliver. That's a kind of value pricing. Solvati was priced that way. And that is why Solvati is actually a bad illustration for, shall we say, greed, because all they ever did is say, we're going to make it roughly the same that you have already been spending, and here's the price. Now, as a board, would I ever have voted for making a pill $1,000? No, because at $1,000, journalists will notice it. Had you made it $885, they would have never even noticed it, right? I mean, who would write an article about that? So the third concept, however, is when you say, I'm going to peg the price on what this product will do for you and the value you attach to that. Now, when you come to life-saving drugs, that's a difficult thing. How much do I assign to my life? So the image I invoke for this to my students is to say, think of someone in the Sahara Desert dying of thirst. This guy is literally on his last leg. And along comes a caravan of merchants loaded with rugs and loaded with water. And one of the merchants takes a bottle of water, Evian, and says, what would you pay me for this bottle? And this dying man would say, everything I own. Everything, you can have all my possessions. Because he figures out life is more valuable than everything he owns. That's value pricing. The deal is done. That's value pricing in its clearest sense, because it's pegged the price on the value of this procedure to the patient. Now, it seems to me the pharmaceutical sector isn't totally there yet at the Sahara model, but they've slouched in that direction considerably. And I think that's a dangerous path for the industry to follow. You just look at the hearings, maybe even in this room, on EpiPen. The average American does not like this value-based pricing model, that it should be based, you have a kid who could die unless you had an EpiPen, and therefore I'm going to charge whatever I like. And the very reaction against that suggests to me that the drug industry is walking down a very dangerous path politically, not economically or theoretically, politically. Now, the concluding observation that I have is, in general, our national conversation about healthcare would be better if we use the word value less often, and if we do use it, that we define what do we actually mean by it, so that people know what that is. Fuzzy language begets fuzzy thinking. There is a lot of fuzzy thinking on the speaking circuit, as all of us know. And in the meantime, I would give you this advice. If you plan to attend a healthcare conference, there is a nifty device that you could take with you, and it's this. So let me end on that happy note.
To get us started, I'll go ahead and ask the first question, and I will carefully avoid the word value, although it would be tempting to use it in this sentence, which is, we've kind of had a smorgasbord here of different perspectives, and I'd like to just kind of pull it together with one question, which is, as this incredible panel thinks about the future, what gives you optimism that we're really going to improve on the three measures of access, cost, and quality? And I'd love for a volunteer to go forward. Bob, and then Mike.
One of the most exciting things, I think, is the data liberation that I referred to. And as a doctor, I remember the first time I got a report card from a health plan when I was a doctor at Beth Israel Deaconess in Boston. I got a report card from Tufts Health Plan that said, Dr. Kocher, you're a Harvard doctor. You're average. I remember calling the chief medical officer of that health plan to ask for the data because it must be wrong, that I cannot possibly be average. I'm far above average in my mind. And they sent me the data, and the data actually was right. I was average on a bunch of measures that they were measuring me against that I wasn't aware of, and I got better quickly. And I took that observation from many years ago with me, and one of the most interesting things today is I'm a professor at Stanford, and we're a Centers of Excellence hospital for almost every insurance company. So if you get sick in California and you have cancer or need a bypass surgery, you're told by your insurance company, go to Stanford. Then I think about what happens when that happens. You might get me. And you don't know if I'm above average or below average. You're just told that Stanford's awesome. And it so happens that when you get the data now, which you can do in California, you can do it actually in every hospital in America, look at the doctor data. What you'd find is that if you needed a bypass surgery, there's 4 doctors at Stanford that do more than 80 of those surgeries a year, and 3 of them are awesome. Risk-adjusted, well below average mortality. I would assure you that your outcomes are going to be great. I would go to them. But one of them's terrible. And there's no system today for that doctor that's 4 times worse than the California average risk-adjusted to protect you for getting that one. And one of the most interesting things, I think, is the idea that we're going to start doing this doctor-patient matching much more carefully. I would tell you as a doctor, we are all good at some things and not good at the other things. If you saw me for what I'm good at, I'm awesome. You saw me for everything else, I used up to date, and I hope I was average. And the most important thing is actually this pairing, and data allows it to happen. I assure you that, like, when I referred, I do my best to send you to the right doctor for you, but my brain's not Google, and it's not a database that actually looks at the actual outcomes, and now you can. And so that's something that I'm really excited about seeing applied. I think health plans, kind of what Jeff said about, you know, if Amazon did it, like, there'd be algorithms that would be a lot more informed than the way we refer patients today, and that will save a ton of morbidity, a bunch of mortality, and a lot of money, because actually better outcomes are cheaper. That's one of the coolest things about healthcare, is that it's cheaper to do the right thing than to pay for the complications. So I'm excited about that.
Governor Leavitt?
I'm optimistic because I believe we are beginning to do hard things. We have operated under a payment system that most in the health business have mastered how to, the word is optimize, which is another word that I am confident an economist could have a field day with. But they have learned how to optimize the coding and to optimize the payment in the system, and therefore we get what that produces. Figuring out how to change that is hard. Figuring out the relationships on where people are in the system. Figuring out systems, like Bob mentioned, to actually evaluate whether a person is average or above average or below average. It's hard. We are pioneering. In the same way, Jeff mentioned businesses that have invented new processes. He mentioned Bill Gates and his capacity to put his goal to put a computer. What made that happen is the internet, and we have now figured out in society how to do very hard things. Well, I think, given the fact that we are being driven not just by a noble purpose, but by economics now to do hard things, that there's reason for optimism. It won't happen quickly, but it is happening, and I think we will ultimately end up with a uniquely American healthcare solution that will make a better system to serve people.
Anyone else want to take it? JD?
We were laughing earlier. Dr. Reinhardt found an article of a mother who was charged for holding her baby during the delivery. It showed up as an itemized bill. What was it, $39 for skin-on-skin contact. The inefficiencies in the current system are so dramatic that it's reason for optimism. You all know it. You have it in your own lives. My wife and I just had a baby. We got charged $6,000 for the audiology test. We were in an in-network hospital. Turns out the audiologist is an out-of-network troll. Right, it's the same test that you and I can perform by clapping. The whole thing took about 4 minutes, and it's a $6,000 bill that you get hit with. Right, you've all had those experiences. I guarantee you had in your own family lives, and it's that level of efficiency that gives us optimism. You can improve on that for sure.
You know, Nancy, I would say that there's widespread acknowledgement that healthcare is not what it
Uwe, do you want to take it as well?
Turn on your mic.
I think life in the U.S. has gotten better over the 40 years I've lived here. I mean, we hear all this talk about with going to hell in a handbasket. I don't actually see that at all. I think life has gotten better, and the healthcare has gotten better, and it gets better every year, I think. There are, however, some strange things that we do, which I hope won't be so uniquely American. I told Nancy yesterday, I'm thinking of writing a blog post. What if I took a random sample of Princeton freshmen, got them really drunk, and then at 4 in the morning, have them design health policy? Would they ever come up with something so stupid as to pay oncologists 6% of the price of a drug they use, so that the more expensive the drug they pick, the more money they make? Even a bunch of drunken freshmen at Princeton wouldn't come up with that. They're not that ridiculous. And you can go, yesterday we had 4 or 5 of these instances where in the US health system, we do things that is just plain idiotic. And they could be fixed very easily, but because of the political powers of people, et cetera, they don't. I hope at some point we will focus on those and get rid of this. And this out-of-network, I personally, when I first heard about it, I was chair of a commission on hospitals in New Jersey. I actually didn't believe when people told me this, because I said no one would be this ridiculous, that you could actually be in a hospital, in network, and the doctor says you need an MRI, and the radiologists are out of network and can hit you with whatever they like. It's such an idiotic idea that you really wonder, would a bunch of drunken freshmen ever think of that? So those are the things that we could get rid of that would immediately make healthcare better for patients outside of the clinical side. I think the clinical side has much improved, although they're good and bad doctors, good and bad professors, good and bad for everything. Overall, I think U.S. healthcare, the quality is pretty good.
Great. So instead of going to the reverse question, I was going to ask them what's keeping us back. I think we all know the answers to that. I'll go ahead and start doing your questions. These are going to jump around a little bit, so I'll throw them out and I'll just ask for volunteers. And the first one is, why is reference pricing not used for services like joint replacement more widespread? CalPERS experience. So I guess what they're asking about is, why hasn't reference pricing taken off, especially for procedures that are more defined? Would anyone like to take it?
I don't know. It makes great sense, and it's something that from a policy perspective, we thought, I think, was going to take off, particularly in the private sector markets. When you look at price variation for all procedures, it's typically 400%. 400%. And when you look at quality outcomes, there's great data now that suggests that there's no relationship between price and quality. And so it makes perfect sense that you could draw a line and be like, okay, colonoscopies, we're going to pay up to this much. There's a lot of supply below that price on Uwe's supply-demand curve. Go to it. I think employers have been a little bit reticent to ask their employees to A, care about the price, B, potentially drive somewhere differently, or C, tell their doctor that the person that they suggested that they go to is above the price, and have that conversation. And then D, most doctors, when they make referrals, have no idea if the person they're referring to is above or below the price. So I think it's probably operational considerations that have made this sort of obvious policy. It's one of the policies that I think the Princeton freshman would have suggested would be a good idea, not take off as quickly as it could. I think it will. I think it makes sense.
But did you want to take it?
Just at this moment, there is a huge email list that Peter Grant supports. And there was a big tinkling match among us policy wonks over the question, why don't good ideas scale up in the US? And 2 highly respected colleagues, I don't want to mention their names here, came out with the research. They're both sociologists. They say it's cultural diversity. It's just simply that you have different cultures, and what works in California can't work in Florida, and so on and so forth. But when I step back from, cultural diversity explains everything and nothing, because you can explain almost anything with that. was stunned by that because this is a country that invented one size fits all. Starbucks being an example, Holiday Inn, Marriott, McDonald's. We invented one size fits all in this country. No other country ever had that. We exported it to them. Even universities are very similar in what they do. Yale, Harvard, Princeton, Berkeley, Chicago, you name it. We do the same things, teach the same stuff. Why is healthcare so different? And one of the explanations I came up with is because the payment side has been too accommodating. If, within the same city, you could have price variations of a factor of 5, and yet they all get paid. One hospital gets paid 5 times as much as another for a normal delivery. And if that's the case, why would you bestir yourself to be efficient and scale up? Because reference pricing is not that easily done. And it has some, it basically says rich people can go wherever they want and poor people have to go where the low prices. It's highly controversial. The drug industry hates reference pricing in the US. So it's not so clear why people in Florida would embrace it. But if they had to, if they were forced to by employers to embrace it, they would. They would, as Americans are very adaptable when push comes to shove. But push never came to shove.
Jeff, did you want to take a question?
Yeah, I'll just add one thing to that. I believe the individual market is a laboratory for things happening in healthcare that can be applied to the employer market. And that's for better or worse. And as an example for that, there's been a lot of criticism of narrow networks. And yet in Washington, when Premera entered the individual market in 2014, we did so with a narrow network and captured 50% market share, which told me that consumers were more than willing to make a trade-off on access for cost. And I think based on the experience you've seen around the country of carriers pulling out of whole states or counties at least, there will be further experimentation with ideas like reference-based pricing. And I think as proven in the individual market, they will expand beyond that segment.
Oh, Mike.
I think, again, we have to acknowledge this is very hard. And it's not going to happen quickly. I think it's important to think about this transition we're in as a 40-year process, not a 10 or a 12-year process. And I would argue that we are 25 years into the 40 years. All that was mentioned earlier today about what happened in the 90s and going through the managed care, and all of that was a learning process because we're changing fundamental business models and we're changing the way people are incentivized to do their work. Whoever it was that said one man's waste is another man's living is absolutely right. And so it is a mix of sociology and economics and politics. And doing this is not just a matter of deciding, it's a matter of implementation. And it's very serious. So I think it's safe to say that we are transitioning, but we're inventing as we go, and we're in a 40-year process, and we're on our way. A lot of the stupidity that's there has to be revealed, and it has to be fixed.
Mike, that's a great transition to the next question, which is, how will medical school residents and students pursuing a degree in healthcare be prepared for these transformations in their education? And anyone want to take it? Bob, you're the only one who's gone through medical school.
They should take my class, and then they'll be better prepared. I wish in medical school they taught us how to manage other people, how to engage a patient and influence their behaviors. What a pharmacist, nurse, social worker, care coordinator, intensivist, hospitalist, SNFist all do. And what's your role in that? Because today we have lots of people complaining about EHRs and the HITECH Act not solving that problem and not completely fixing the communication and sharing of information such that patients get care that actually works well for the patient. And so I think some of the things that I'm seeing is the mixing of classes in medical school such that doctors and other clinicians are trained together both in the didactic section and on the clinical rotations. I'm seeing many medical schools that I give lectures at teach basic data analytics, and a lot of the things that you learn in business school about managing other people, giving feedback, having conversations, making eye contact, all that stuff. And so I think that we're on the beginning of the redefinition of how you teach doctors to work. But doctors increasingly are going to be managing teams that care for patients and have to actually care differently for different patients, back to the Starbucks analogy. So a sick patient needs different types of care, different engagement, different understanding, and different shared decision-making than a younger, healthier patient. And so I think that there's a lot of imagination to be applied, but I think we're recognizing, particularly because many now medical schools are ACOs and actually have populations they care for, we're waiting to see it. I think that a lot more of the school should be done in the outpatient setting in places like primary care clinics and community healthcare clinics, because that's also where you learn about what it's like to be a patient. The last thing I'll say on this is one of the most important things I've ever done was I spent a day living with a patient who had chronic diseases in her house, and she was a single mother with 2 kids, and she had a pill box with 90 different slots with her pills in it and a calendar that had all of her doctor appointments and lab visits on there with her work schedule. And the thing that it impressed upon me is that it is super hard to be a patient, and nobody wants to be a patient. And that what we ask the patients to do is probably impossible relative to her living a life that is joy-filled and supports herself and her family. And when you understand it kind of in that dimension, you appreciate, A, all the things others can do to make care better and how important the team is, but you also understand that what you have to consider, like what you're asking someone to do, because we often blame the patients for a readmission or for a failing to achieve a clinical outcome. And when you see what a patient actually has to do when they have a condition that's hard to manage, you realize that we're doing our best just to try to make them suffer less and that you have to rely on others. And so I think that's an important part of what teaching doctors should be in the future, is actually thinking about what we're asking the patient to do. And I hope, back to the 40-year journey, that medical school is a lot more like that in 40 years than it is today.
That's a nice transition, and this question I'm going to call on you, JD, which is, do you envision that the healthcare system, plans, and providers will start designing using alternative payment models that try to address non-clinical social determinants of health, housing, food insecurity, and employment? And I call on you because of your program that you spoke about.
So I would absolutely agree that those, including those other spend categories, are key to managing the cost curve over the long term. And it's, ironically, it's actually easier in the big government programs. It's easier when you're dealing with the state government because they, particularly we talk about some of the subpopulations, we've got categories of individuals, I guarantee you do in your own state, where if you add up all of the spend, cost of education system, all the social service departments, all the healthcare, you're spending well over $500,000 a year on some of those families. And again, the quality of care, the quality of service is awful, right? If you had to live in their shoes, it's a terrible experience. You got to go program to program. You may have 7 different care coordinators across each one of those programs. So it's absolutely key. Ironically, it's actually easiest, I would say, with the state government programs. Is it going to happen anytime soon on the commercial side? I'm not sure it is. Others at the table may have opinions on that, but that's certainly where it's at.
Mike?
While I was governor, I actually experienced this. We would have we had many families, and we knew their names, and they would have 6 or 7 different care coordinators, if you will, or program managers. And we would put them at a table, and they would begin to talk because none of them knew what the others were doing. And I do think, particularly in Medicaid, that we're very close to seeing a point where Medicare, particularly payers who are managing this, or providers who are managing this and being in some form at risk, are going to ask to have the ability to bring, and we're talking about transportation, we're talking about work, we're talking about, in some cases, juvenile court. There's a lot of different services that could be wrapped up and served much, much better than either the state or the Medicaid providers now providing them. And now that they have a financial stake in it, I don't think we're very far away from seeing people being willing to do that.
Great. Somebody submits this question. I did not hear the panel discuss 2 important topics, 1, prevention and wellness, and 2, non-clinical cases. I think we've just covered that, so let's focus on the prevention and wellness. Does anyone want to talk about the role of prevention and wellness as we look to the future?
Well, I think, obviously prevention of illness means you're just buying more quality adjusted life years than you would otherwise had, which is a good thing. But people who think that that'll save money or lower healthcare spending in the future, almost all the research I have seen says no, that it won't do, because in fact people will live longer, consume healthcare more, and in the last 5 years they will rack up a huge medical bill anyhow. So the idea for preventive care somehow being a solution to the healthcare cost crisis, I would reject from all I've read. The idea that you get more quality of life years is a good thing, which therefore I support the idea of preventive care. Some of the wellness programs in corporations remain controversial, Bob. I don't know what you know about it, but from what I read in the literature, sometimes it works. I think Johnson & Johnson was said to have a very good program like that, but others had not such good experience. Maybe you can say something.
Yeah, I agree with your summary. The problem with wellness and prevention is that it works sometimes. And so in this room, some of you right now, if I talked to you about changing your diet, you'd be intrigued, and then you would. And for some reason, you would remain in your new diet forever, and you'll be healthier. Most of you, when I talk to you about how to change your diet, will politely nod and try it for tomorrow, and then go back to what you liked before, because that's what you like. And there wasn't that moment in your brain where I rewired your neurons and changed your serotonin levels enough to make you stick with it. And so then if I spend $800, like a lot of employers do, to try to get you to be more well or prevent something from happening, that money's wasted because you weren't susceptible to that change. And all these programs suffer with engagement curves that basically always start with a flurry of balloons and announcements and contests to get a bunch of employees to start something. And then if you look 12 weeks out, you're very lucky if you have more than 3% of the patients or the people doing it anymore. And then when you say, well, what's the value, sorry, Uwe, what's the cost savings that comes from those people doing that this year? It doesn't pay for the program. And that's sort of what the data says. But for those who do, they're evangelical, transformed, happy people that are more well and happy that tell you should do it some more. And so you sort of get this perpetuation of these programs that aren't that effective because we can't figure out how to actually make anybody's behavior change. And BJ Fogg at Stanford gives all these lectures about how you do it, but we haven't cracked that code. Nothing is as engaging as Facebook or Candy Crush for that matter. And until we have healthcare wellness and prevention programs that actually are like consumer products in terms of their engagement, they're probably not going to be cost effective.
I say Uwe and Mike.
Yeah, I once read a story about a patient whose doctor gave him all kinds of advice of prudent living. And in the end, the patient said, doc, I'm willing to do all this stuff, but will I actually live longer? And the doctor said, that I don't know, but it'll certainly seem longer.
Well, consistent with that, I'll just say two things. One, while I was Secretary of Health, best I can calculate, we spent about $600 million trying to affect in a positive way obesity and to change people's habits. And actually, midterm through those programs, they were discontinued because we couldn't see any particular gain from them. Second thing I will say is that some months ago, I was in an airport, and it was about 10:30 at night, and I'd had my plane delayed 3 times, and the only thing that was going to fix it was a Big Mac and fries. And I got to the counter, and I felt this kind of wave of anger come over me because it was in a state where they had required there to be not just the price, but the calories. And it interrupted.
That's the Affordable Care Act working for your health.
Well, and it changed my behavior. And it didn't cost $600 million. I think there are things that society can and should and will do. I think the efforts we're making to begin to connect premium pricing with various health measures beyond tobacco, I think it's a very positive thing because it is beginning to change, to make people aware and to change behavior.
Let's turn to Medicaid for a moment. So what does the future hold for Medicaid expansion under a Republican or Democratic administration? What are the prospects for Paul Ryan's block grant proposal, and would it mean for states already facing budget pressures? Anyone want to tackle either the need for Medicaid expansion or the likelihood of it? JD? As our Medicaid expert.
Tennessee's a state that our governor championed Medicaid expansion, but it was not embraced by the legislature. We're big proponents of it. Our mission is providing health care to Tennesseans. It's the right thing to do. That said, there are real challenges for states with these programs, and everybody knows it. They're massively cumbersome. They're fiercely anti-cyclical. Just when your economy goes down as a state, these programs tend to swell in their enrollment, and states can't print money. And we see it time and time again. If you look out over any long period of time, states get in trouble with these programs, and they end up having to do terrible cutbacks. So we're big proponents of Medicaid expansion, but there's got to be some innovation. There's got to be more waiver flexibility in order to do them in ways that are fiscally responsible if they're going to be stable, if they're going to serve the populations they need to serve.
Anyone else want to take it on? No. All right. So we'll have one more question on the ACA, and that is, as you look forward, and Bob, you did a great job kind of summarizing some of the great things that the ACA has done. But when you look forward, what about the stability of the exchanges and remedying some of the problems people are seeing with it, especially when we have such a divided country and the view of it is so mixed out there? And of course, we have a very divided Congress as well. Trump, Clinton, it doesn't matter. We're in a very divided way. What's going to happen to the future of the ACA? Mike, you're so brave. Thank you, Governor.
Again, I think we have to think about this transition we're in as a 40-year proposition. And there will be ongoing iteration for that entire period. And I would doubt there is a Congress in the next 15 years that will not have substantial work to do in the context of continually iterating this process. Now, there are some philosophic divides that clearly we confront, and we won't know how that will play out in this next iterative cycle until after the election. But I think it's important to acknowledge that there is progress being made, and there's an argument over whether that was because of the ACA or because of the unintended consequences of the ACA. But iteratively, we're moving it forward, and that's what we had the optimism conversation earlier, and that's why I'm optimistic.
Can I get Jeff in there, and then I'll come to you, Bob?
I just comment that very few things are ever written once and never change, perhaps the Ten Commandments. But when the ACA was crafted, I don't think anybody thought, Republican or Democrat, that it would never be edited again. It would never be tweaked, modified, improved. There's been no other piece of public policy in American history that Congress hasn't actually, over time, evolved and changed. And so I'm hopeful that we'll get to a point where we actually do make constructive improvements to the ACA, because you learn as you implement a law and see what happens in the economy, and you learn how to make it better. And so I'm hopeful that we'll begin to do that and stop sort of rankering about whether or not we should have it at all and get on with the 40 years of making it better.
Jeff?
Well, there are two calculations around the ACA. One's political and the other's economic. So in this town, it's generally on the former, but in JD's, in my world, it's on the latter. And we have to think about the financial aspects of the ACA. And I think that while we're on a 40-year journey, there are some harsh realities coming in the next few years, absent changes that Bob's described. And that as health plans, we're faced making those decisions, and those will come very fast, very soon. For instance, in Alaska, we're the last carrier standing up there. Everybody else is pulled out. And absent a $55 million appropriation by the legislature and governor there to establish a reinsurance pool for high-risk individuals, it's likely there would be no carriers in that marketplace. And that's in part because the market's so small. Alaska's unique in that regard. but because there are a lot of loopholes in the law too. So again, to the extent improvements are made, that's a place where they need to happen. And I think that scenario is playing out all over the country. You see companies making that calculation about whether they can be profitable in the individual market long term, or even short term, frankly. So I think there's aspects of the ACA that could be in jeopardy in the next few years if there's insufficient movement in this town.
JD?
Just let me emphasize one point that Jeff made. April 2017, that's when most of us submit our bids for the next calendar year on the Affordable Care Act. That's not so many months away. In most states, the Blues are the only plan left, or one of a few. Collectively, by my math, the Blues system has lost over $6 billion on the marketplaces since they went live 3 years ago. There are some real fixes that are needed, and we don't have much time. Most of the CEOs in the Blues system, or anywhere in the system that I talk to, are saying maybe one more year is all I can hang on, which means some of those fixes need to be very quick in coming before that April 2017 date.
We're going to give you the last word on this, and then we'll wrap up.
Yeah, there is unfortunately a lot of demagoguery around this, particularly against the insurance industry. The fact is that if you have a commercial insurance industry, for-profit or not-for-profit, it doesn't matter, and you tell them by regulation, you have to charge the same premium to people, to applicants, whether they're very sick or very healthy. That is an actuarial nightmare from a commercial point of view. In fact, it just cannot work. How do we know this? Well, we had it in New Jersey, where we had a community rating for the individual market, but no mandate to be insured, and that market pretty much collapsed. There was an article in Health Affairs by Monheit that demonstrated that. New York had a similar thing. I think in the end, per month, it was $6,000 per family, because only very sick people. People have to understand that unless you can force healthy people into the exchanges, as the Swiss do and the Germans do and the Dutch do, unless you can do that, this system is very fragile and unstable, unless either you're willing to raise substantially the federal subsidies to the insured, because most of these people will be sick people and the healthy won't be in there. And secondly, think of a reinsurance mechanism that works better than what we have. The Swiss have that. It's not perfect, but it's better than ours. The Germans have it, the Dutch have it, and here we're litigating over the risk corridors. So in some way, there's sabotage of what we have, and secondly, the mandate is too weak. Even though we have this age band, I think you want to go from 3 to 5. I don't know how much that'll do for you. But it is a tricky thing to have community rating, as that's called, with a very weak mandate, and sort of somehow blaming it all on greedy insurance companies, I think shouldn't be done, because it doesn't go to the actuarial problem the insurer really faces.
That's going to have to be the last word. You all have been an incredible audience to hang in here to the end. Look at all these questions that you submitted. We weren't able to get to them. I do have a couple of thank yous, if you could just wait. I'd like to thank Congresswoman Diane Black from Tennessee's 6th District for sponsoring our event. I'd also like to thank my amazing team, Catherine Sontera, Katie McDonald, Carolyn Myers, Kate Ellis, Kristen Wade. They've just done a terrific job for us. Most importantly, I'd like to thank our amazing speakers, so please join me in a round of applause for them.